So the background why this talk is there, we see a lot of calcification in almost all vascular beds, from coronaries to all peripherals. And the reason we see calcification is mainly because of diabetes, patients with CKD, increasing age, and of course dyslipidemias. And quite often calcification may be associated with occlusive disease. If we need to break this calcium, we need high pressure balloons, and there is a risk of rupture. And when you are looking at accessing through the iliacs or the infrarenal aorta, calcified lesions, they act as a barrier to these large bore devices. So we propose using IVL. Now what does IVL do? IVL is intravascular lithotripsy based on the same principle of extracorporeal lithotripsy where you break stone. It uses low pressure balloon platform, and that is a big advantage because you don't really dilate the artery with high pressure. It uses high amplitude and low frequency shock waves which pass through the calcium and crack it. The calcium is fractured in situ, the intimal calcium as well as the medial calcium. It does not harm the soft tissue. And while there is a risk of dissection, the risk of major dissection is low. In fact, in a registry series published in JACC from multiple European centers using IVL for TAVR, the risk was about 2% for major dissection. What we have available in India, the maximum size of the balloon is 8. Of course, in US, we have bigger balloons also available. So if we are going to crack the aorta and we need bigger balloons, we could probably use a single 8 mm balloon, or we could even use a combination of balloons. All of them are over 018 system. So what we do is we deliver the catheter to the lesion, generate sonic pressure waves using lithotripsy. The calcium is cracked. And while this is being done, the balloon is only partially inflated. And once the calcium cracks, you completely inflate the balloon. So where do we use this? In the peripheral arterial system, of course, we use it for almost all the vascular beds, the aorta, the iliacs, SFA, tibials. Even there have been reports of this being used in the renal and the SMA. In difficult accesses, pre-TAVI, pre-EVAR or TVAR, and there is a case report published very recently for a chimney EVAR where the right renal artery, before putting the chimney, the calcium was broken using IVL. Now, why use it? Typically calcified iliac arteries. The approach going from the femoral is a very standard approach for most vascular procedures or cardiac procedures. Instead of changing the access or treatment option, we can actually crack. And if we use the standard balloons, crack and then put stents, there is a risk of rupture because quite often we are using high pressure balloon mounted stents. So IVL uses low pressure inflation, cracks the calcium. It improves vessel compliance, and especially when we are doing EVAR and we have those iliac limbs coming into calcified iliacs, the apposition is much, much better, reducing the risk of endoleak. And these are some examples. This is a case we did. This is a plain view. You can see grossly calcified aortoiliac segment. You can see a lot of calcium on angiogram, and this is post IVL and placement of stents. These I have picked up from different sources. Here the patient was to undergo EVAR, and you can see so much of calcium with the aortoiliac segment. Post IVL, you can see that the iliacs open up very well, and this is a follow-up CT. Another case with severe calcification, and again you can see extremely narrowed iliacs, and of course they are calcified. And this is the IVL balloons in situ, and you can see both the iliacs, the right and the left, dilated, and post-EVAR. This is a case I have borrowed from a colleague of mine working in Dr. Rajiv's hospital, AIG. So this is a lady who was coming with repeated hypertensive episodes. There was a very tight stenosis in the aorta just above the celiac artery, measuring around 6.2 mm. And she was considered extremely high risk for open surgery, where we could have normally done an aorto-aortic bypass. And you can see the pressure gradient. And this is the angiogram, the two views. So an IVL was used here. He had planned to use 2.8, but I think one balloon ruptured, so he ended up using 1, and then subsequently dilated with a high-pressure Mustang balloon, 14 mm. And you can see that the aorta looks good. The pressures have equalized. The important thing is it's very close to viscerals. So the only extra step that had to be done was place a wire in the SMA, and the rest of the procedure went quite well, and there was no major dissection, and the patient did quite well. So while this is not used for large bore access, just to highlight how useful the procedure can be. And these are some slides from the company website, where again you can see pre-EVAR, a lot of calcium in the aortoiliac segment, and here you can see IVL being used, both sides, and after that EVAR being done. And this is a patient who had a stent, and distal to that, this is an EVAR, and distal to that there is a lot of calcium, again broken with IVL, and then a TVAR done. Again, 85-year-old lady, critical aortoiliac stenosis, post-IVL, and you could pass the TAVR device. So in conclusion, we will see more and more of calcified lesions because we are seeing more elderly patients, we are seeing more diabetics, we are seeing an increasing incidence of CKD. And we are, of course, using more and more large bore devices for various procedures. The cardiologists definitely are moving ahead with so many different procedures. And IVL seems to offer a reasonably good strategy for accessing such lesions. Thank you very much for your attention.